My name is Nicole Toyzan, and I am a registered nurse, here to discuss improving effective screening for female urinary incontinence at the Well Woman examination. So what is urinary incontinence? Urinary incontinence, or UI, is defined as any complaint of involuntary loss of urine, and there are four main types of UI that negatively affect women. The first includes stress urinary incontinence, affecting 15%, and occurs with any increased intra-abdominal pressure, such as with coughing, sneezing, running, or lifting. The second type is urge urinary incontinence, affecting 10 to 15%, and includes leakage with a strong, compelling urge to void. Some identifying factors suggesting urinary urge incontinence are leakage on the way to the bathroom, putting the key into the door, or washing your hands, as well as with triggers such as cold water, running water, or seeing a toilet. The third type is mixed urinary incontinence, affecting 15%, and includes the presence of both urge and stress incontinence. The fourth type is coital urinary incontinence, and includes the involuntary loss of urine during sexual intimacy, including during arousal, penetration, and/or orgasm. This may occur in up to 66% of women who report UI and has a significant negative impact on quality of life, including impaired body image, fear of intimacy, and avoidance of sex. I also chose to include nocturnal enuresis as it is quite common, and this includes any nighttime urinary leakage. Prevalence. UI is estimated to affect 10 million American women. It increases with age and it decreases quality of life. It's estimated that UI affects twice as many women as it does men, and the American Urogynecologic Society reports that UI affects about 25% of young women, 44 to 57% of middle-aged or postmenopausal women, and up to 75% of older women. Women 78 to 90 years of age have the highest prevalence of UI, over 45%, and a disproportionate risk for devastating consequences, including poor physical and mental health, reduced quality of life, disabilities with activities of daily living, nursing home placement, and early death. UI is identified as a prevalent, costly, and poorly treated syndrome in women, which incurs greater than $19 billion annually in healthcare costs. So why should we screen for UI? UI is recognized as a global public health issue that causes social and hygienic distress. UI is considered a significant disease of morbidity worldwide with an economic burden that is personal, extends into the workforce, and contributes significantly to national healthcare costs. Women are often too embarrassed to report UI and may not disclose these bothersome symptoms to their provider for years. Women commonly fail to report incontinence to their provider for an average of 4 years due to embarrassment, shame, or thinking that nothing can be done about it. UI is considered an underreported and underserved significant healthcare condition for women worldwide. Women often carry the burden of incontinence without reporting it because they think that it is normal. Additionally, providers may fail to assess for UI due to their lack of knowledge of treatment protocols and not feeling confident to discuss this problem with women. Ultimately, we should screen for urinary incontinence in our patients to improve quality of life and health outcomes. UI has been significantly associated with increased anxiety, depression, sexual dysfunction, sleep disturbances, reduced work productivity, and loss of sense of well-being. UI screening in primary care. In a cross-sectional electronic survey of primary care providers, only 75% of PCPs self-reported that they routinely screen for UI. However, the Women's Preventative Services Initiative recommends screening all women for urinary incontinence annually and states that screening should ideally assess whether the woman experiences UI and whether it affects their daily activities and quality of life. It also recommends that although increasing parity, advancing age, and obesity are associated with an increased risk for UI, these factors should not be used to limit your screening. The UPSI also recommends referring women for further evaluation and treatment if indicated. The Fifth International Consultation on Incontinence Committee provides guidance in recommending the use of standardized questions for the initial assessment of UI, and validating health questionnaires and patient-reported outcome measures are useful for the evaluation of UI and its response to treatment. The annual Well Woman examination provides an appropriate time and place for screening all women for UI. This is an example of an updated, revised urinary incontinence scale that can be given to every patient at their health maintenance examination after checking in for their appointment but prior to seeing their provider. Greater than 3 points qualifies them for a discussion with their provider about these symptoms, and greater than 8 points qualifies them for a referral to either a physical therapist, urogynecologist, or urologist, depending on what this specific patient needs. Questions 1 through 5 assess for different types of urinary incontinence, which can be correlated to their score on the right-hand side of the screen. Questions 6 through 8 assess for how often they experience leakage, how much urine they lose each time, and if it interferes with their normal daily activities. This allows them to get a severity of urinary incontinence score. Scores range from 0 to 26 points and gives you an idea of how much these symptoms are interfering with their daily life. This is an example of a shared decision aid that can be used to guide a discussion about how to manage UI in a patient visit, as well as getting the patient to commit to specific ways in which they plan to work on improving their UI until they're able to see you again in the office. Although the shared decision aid is a bit limited in the types of incontinence it mentions, it does mention the most common types of urinary incontinence and mentions that leaking is never normal. It lists risk factors as well as explains what bladder irritants are and has a list of specific bladder irritants to try to avoid in your diet. The second page shows ways to start working to improve your symptoms, including lifestyle changes such as bladder training, meaning emptying your bladder at least every 2 hours, controlling fluid intake to 64 ounces daily, avoiding straining with urinary and bowel movements, improving constipation by taking a stool softener daily like Miralax if needed, avoiding bladder irritants, weight loss through diet and exercise daily, start Kegel exercises, and making a commitment to drink more water. The middle portion of the second page explains what pelvic floor muscle exercises are and how to perform them at home, as well as what the benefits of Kegels are. The bottom portion of the second page allows the provider to check specific interventions that the patient plans to work on until they are able to be seen again in the office. These include making 3 lifestyle changes, doing 3 sets of Kegel exercises daily, starting pelvic floor physical therapy, starting medication treatment, and, of course, discussing future concerns with their provider as they continue to arise. Thank you so much for watching this educational video and being so willing to participate in my quality improvement project. Please take a few minutes to complete the post-survey after finishing this video. And these are the references that I used throughout this presentation. Thank you so much for watching.